Good evening, Endo Summit Live, and welcome to our second in this series of fertility webinar. Tonight is very, very exciting because we're going to talk about something near and dear to my heart, which is egg quality and rejuvenating the ovary for better IVF results. Please welcome, of course, our embryologist host, Emma Lazzaroni Tialdi, and Dr. Murhai. Go ahead and introduce yourselves, team.
Sure. My name is Dr. Murhi. I am the medical director for Rejuvenating Fertility Center, New York and Connecticut and Nassau, the Bahamas. And I'm also an associate professor at Albert Einstein College of Medicine and Maimonides Medical Center in Brooklyn. So thank you so much for having me, and I'll be talking today.
Good evening, everyone, and welcome back. I think many of you already know me. I'm Emma. I'm a senior embryologist and reproductive scientist. I work in IVF lab for almost 20 years, but now I'm focusing more on fertility education, research, interpretation, and helping patients truly understand the science behind their outcomes. Okay, so as we know, this webinar is a part of Endometriosis Summit mission to bring evidence-based conversation to everyone. Mainly now I direct SC Fertility Immunology, where we integrate embryology, reproductive immunology, and endometriosis care to evaluate why implantation or pregnancy may not be happening and how to approach it in a more personalized way. Okay, before we begin, I want to thank again Sally for organizing this webinar and continue to create this kind of space that is so important for many women. Okay, now it's Dr. Mary turn, and I'm very happy, and I thank you for being here.
Well, thank you so much. Thank you so much for the introduction. I'll be talking today about topic called ovarian rejuvenation, and I try to connect this topic to endometriosis. It's an Endo Summit topic. So the title is, Can Ovarian Rejuvenation Rescue the Endometriosis Damaged Ovary? So the purpose of this talk is to define ovarian aging and endometriosis and its effect on female fertility, to discuss the different types of ovarian rejuvenation, and finally to talk about the drawbacks and limitations of all the procedures that we're currently doing. And before I start, I want to say that ovarian rejuvenation is really a clinical term. It's not really a scientific term that's used in medical literature. I think the proper way to say it is more ovarian enhancement or something else other than rejuvenation would be probably more proper. Now, here it's important to talk about how ovarian aging and endometriosis interact together. The hallmark of ovarian aging and ultimately ovarian insufficiency is related to all these events: DNA damage, apoptosis, inflammation, mitochondrial damage, and we see all those things also worsen during endometriosis. So that's why we know that endometriosis could impact reproduction and could be associated with poorer ovarian reserve and quality and poorer IVF and fertility outcome in these women. Now, let's talk a little bit about someone, even if they're in menopause. It's very important to know that even menopausal women, when they tell you, oh, you're in menopause, you have no eggs, actually, that's not true. There is 1,000 eggs left inside the ovary of every menopausal woman. We know this from 100 years ago, where they did hysterectomy on postmenopausal women in their 50s. They took out the fibroid, the uterus for the fibroid surgeries, and they removed their ovaries and sectioned them and looked under the microscope, and they found, on average, 1,000 dormant primordial follicles. And this is why the concept of ovarian rejuvenation started in Greece 10 years ago. But let's talk about the consequences of ovarian aging by endometriosis and on infertility. The egg quality and quantity is one of the most important factor in IVF, as we all know. It is observed in up to 25%, I believe it's a little bit more now, 25% of women undergoing IVF, leading to low ovarian reserve, premature ovarian insufficiency, poor egg quality, more abnormal embryos, and finally menopause. And that's why there's a huge need for ovarian rejuvenation. And as I mentioned earlier, the Greek people 10 years ago started the concept of ovarian rejuvenation because they noticed postmenopausal women have 1,000 eggs, and they were able to make a lot of those women ovulate after ovarian rejuvenation and have babies with their own eggs up to age 46. And this is data from 10 years ago. Now, what is ovarian rejuvenation and why endometriosis matters? Ovarian rejuvenation is a medical term aimed at improving the function of the ovaries, really focusing on the egg quality and quantity. It's really more about the quality, honestly, than the quantity, and this is what we care about. It often involves using various methods to stimulate the ovaries and enhance the ovarian function, and it's still emerging. It's very important to know that we still are studying it, and the results vary from center to center. But it's very important to know for this conference is that endometriosis patients represent a major patient population who seek ovarian rejuvenation because they're more likely to have low ovarian reserve, low AMH, high FSH, and poorer egg quality. There are three types that we're going to talk about tonight. The first one is PRP, the second is adipose PRP, and finally the stem cell and stem cell exosome. These are umbilical cord derived. Now, the PRP, if you take a blood and centrifuge it and look under the look at the tube, you'll see three layers. The middle layer is the one that's platelet-rich plasma, and this is the layer that's used in a lot of things, not just ovarian function. It's been used for decades for athletes, for their joint. It's used for healing dentistry, used for facial rejuvenation, hair loss, a lot of other things. But the Greek people were the first to start for ovarian rejuvenation 10 years ago. And what they did is they took blood from patient's arm, and these were postmenopausal women, centrifuged the blood, removed the PRP, and then step 3, they injected under ultrasound guidance inside the ovaries of those women. Now, why and how, what mechanisms PRP works in? It's, if you see at the some of the elements, I didn't put all of them because there is way much more. A lot of elements and factors and growth hormones are present in PRP. And this is one of the most important mechanisms by which it works. Why? Because as I mentioned earlier, if you look at the hallmarks of ovarian aging and inflammation, a lot of those factors counter effect those bad things that's happening to the ovary, and hence improving the quality of the whole ovary in general. Now, to date, there are no studies in particular published about PRP and endometriosis. However, it's very important to note that endometriosis, according to the American Society for Reproductive Medicine, ASRM, up to 50% of women who have infertility might have endometriosis. So really, if you look at these data, even though they did not tease out endometriosis, a lot of those patients pretty sure they have endometriosis. But we have shown that PRP ovarian rejuvenation could improve blastocyst yield and euploidy rate in women undergoing IVF. There are studies in mouse where they put PRP in the in vitro maturation culture media, showing improvement in embryonic development. More studies where they did chemotherapy-induced ovarian damage to the mice, and then they did PRP, and the PRP was able to restore some of the oocyte, some of the egg quality and ovarian function and embryo development. Statistically significant improvement have been shown in number of follicles and AMH. And we have published a case report on women with PCOS where women and this is very important because it's a big area for future research, is we did PRP for women who have PCOS, and she did not want medication, and she was able to ovulate on her own for up to 3 months. And also her testosterone and other androgens improved significantly. We published it in JCM case report. Just something is to focus on for future researchers. And finally, we also looked at, and we notice it every day, but we looked at systematically in patients who have hot flashes, and we were able to get one patient who up to 13 weeks was documenting her symptoms as far as hot flashes, sleep, activity, all those. And there was significant improvement in a lot of those parameters for up to 12 to 13 weeks. So it's worthwhile noticing that it's not just about pregnancy. The ovary has a lot of other things like testosterone, androgens, androstenedione, DHEA, so many things that we don't look at on daily basis. And I can tell you, a lot of my patients say, well, my libido improved, I sleep better, all those things following the PRP. So even though it might not work for everybody for the egg quantity slash quality, it does help a lot of people with other hormonal benefits as well. Now, not every study showed improvement. This is one of the trials that was shown that showed that the PRP increased the number of eggs without increasing the quality of developed blastocysts. Very well, nice study published in Human Reproduction, and it took a lot of popularity, but it's very important not just to read the abstract. And this is what I tell a lot of people who just jump out of conclusion by reading the abstract. It's very important to read the studies and the methods, because you can't look at something that's done, I'm just giving an example. I'm not talking about the study. Something done in Finland population and translated to New York population, because they're totally different patient population. But this study, even though it was well done, we submitted a kind of like letter to the editor, pointing again. They're great study, great people, but they had a lot of, if you look at the details, a lot of issues with the PRP, how the preparation was done, how that was administered, the sample size calculation of the study. Because when you don't find significance in outcome, it's very important to see the power of the study and to make sure that the sample size is enough to catch, the statistical significance. Also, a lot of those patients underwent conventional heavy stimulation following the PRP. So again, it's well done study. However, we need to really look at the detailed methods of a study before we jump to conclusions. That's all I'm saying. Now, as far as PRP, right? It's how it's done, it matters a lot. I'm looking here. If you look at the ovary is complex. There is the inside, which is the medulla, that doesn't have eggs, and the outside with cortex, where the oocytes are. So if you really inject in the middle, you're not gonna get much effect, right? So that's very important to know, and that's why I always tell people PRP, if you did it in place A, it doesn't mean it's not going to work in place B, because it's injected differently, and it's important to know where to inject it. The needle size is important. I know it sounds stupid, but it's not, because the ovary is small, especially in women with low ovarian reserve. And if you use a big needle that's half of the size of the ovary, it's going to leak out. It's not going to be retained, right? So you really need a thin needle. It's like sponge. Go in, inject, so you can have that PRP stays and soak the cortex area. Now, how much PRP you're injecting is also very important, right? You can't, half a cc or 3 cc's makes a big difference. How many injections, this is a key, how many injections you're injecting is important. A lot of clinics, they do one injection. I don't think, with all my respect, is enough, because the cortex is like a circle. So you really need to cover as much surface area from that ovarian cortex as much as possible in order to get the outcome. Now, I always tell people that ovarian rejuvenation or PRP is not magic. It's not gonna just always, it can be magic, but most of the time it's not. And what you do IVF protocol wise after the PRP is very important. If you are going to go and pump yourself with shots and Menopur and high dose, I don't think patients should waste their time with PRP, honestly. It's not going to work. Now, the protocol, and especially in women with endometriosis, why? Because they have inflammation, and the more you pump them with shots, the more you actually cause inflammation, and the higher the estradiol, and the worse the outcome. So it's very important to determine if you're doing traditional IVF versus me. If you're doing traditional IVF, with all my respect, it's not going to work, right? There's plenty of studies, 1, 2, 3, 4, 5, and more, showing that the more the dose you use, the more likely you get abnormal embryos, the more likely you get genetically abnormal embryos. This study, the second one in endocrinology. Endocrinology is very hard journal to publish in. They explained how excessive FSH stimulation is bad for equality and steroidogenesis. Beautiful. I highly recommend people eating it. So it's very important to not pump yourself with a lot of dose of medication following the PRP. Now, it has a lot of drawbacks, limitations. The research is still limited. There is no perfect study as of today. I mean, there's no perfect study in the world point, but I really think we should strive to have better studies. The variable results varies. Like I said to you earlier, endometriosis, up to 50% of patients undergoing IVF, they have that. So is women who have endometriosis doing better or worse on PRP? We don't know, because we really have not really teased out women with endometriosis versus not, and the PRP to see the difference. There is potential side effects like egg retrieval. PRP, you use exactly the same vaginal route, infection, bleeding, anesthesia. Those are risks. Cost is risk. Ethical concerns, temporary results, psychological impact, especially when you have hope and it doesn't work. It's devastating for a lot of patients. And also the regulatory approval. There's no regulation on how it should be done with how, so it's really not very well regulated. Now, the future directions and clinicians, and in order to have a better answer to things, it's important to have standardized preparation method. It's important to have standardized number of injections per ovaries. It's important to standardize the location of injections, the volume injected per ovary, the needle size, how many times PRP should be done. Was one time is enough, or you want to do it every month for 3 times, or it's unknown. And finally, whether endometriosis affect the results or not. Those are the unknowns, and these are the things that we need to strive to kind of standardize in order to help the community have the right answer. Now, we're going to transition to another type of ovarian rejuvenation, which is called the adipose PRP ovarian rejuvenation. It is PRP plus adipose, and adipose is the fat. And believe it or not, the fat and our bone marrow, they have a lot of stem cells. So the reason why we looked at adipose PRP is it's a very rich source of stem cells, much higher concentration than bone marrow. It's much easier than bone marrow to get with mini liposuction. And finally, it has superior properties because though the adipose stem cells can respond to hormones, good. 2, they have low immunogenicity, so there's little risk of inflammation or infection. And 3, there are some studies have shown that these stem cells could potentially become new oocytes and new eggs. So if you look at the stem cells, there's plenty of stem cells. There is multiple lines. This is here the more differentiated. As you go back up, you back to the origin. So really the totipotent is the best one, but this is really embryonic stem cell. And embryonic stem cells should be the best, but because there's a risk of cancer, well documented, we don't use them, and we can't use them, and I'm not interested in using them. And another type of stem cells is the induced pluripotent stem cells. Those are the two probably one of the best, but also they have the potential to become cancerous. So that's why we use adipose stem cells. There's multiple types of stem cells. Many studies looked at all those things. Believe it or not, now, not number five, menses have stem cells that comes from the lining as well. They also have been studied a lot. So there is a lot of awareness, and it's really amazing how God made us that we have our own, which we could treat our own body with our own body, right? It's really amazing. Now, this is one of the studies where they showed the adipose tissue stem cell become mesenchymal stem cells and ultimately make a follicle and an egg. It is, I want to make it clear, other studies could not replicate this or were not able to show that these stem cells could become eggs, but it has been shown in certain studies that these stem cells from the fat could become eggs. But guess what? These are younger eggs made fresh, born now, better everything mitochondria. So they tend to do better job and might yield in better quality eggs and embryos. Now, when you ask me, how do these adipose stem cells work? What's the mechanism? It's not just by becoming new eggs. They work through 6 different mechanisms, as you see here. A lot of them are antioxidative stress, anti-apoptosis, immunoregulate effect, improve folliculogenesis, and improve angiogenesis, which basically the formation of new blood vessels and better oxygen to the eggs. And as you see, a lot of those are problem in women with endometriosis. The question is, are adipose stem cells best for women with endometriosis? Again, I don't know. There is no studies really teasing out endometriosis with adipose PRP. But if these other mechanisms that's involved in endometriosis and the adipose stem cells could reverse those, that would be great. The procedure is, the adipose procedure is mini liposuction from the belly, tiny hole. It's actually less than 1 centimeter. And then we take a little bit of fat. Then we use FDA-approved kit, progeny, I can never say that word, progenikine concentrating system. And finally, we add the adipose to the PRP. Now, why we can't in the United States, according to the FDA, we cannot use any major manipulation. We cannot add enzymes, collagenase, and others. And that's why we do it in a very simple way with very minimal modification in order to abide by the FDA rules and regulations. So this is a summary. Step 1, we take blood. We take patient to the OR. We do mini liposuction, remove a little bit of fat, remove as many fat cells to concentrate stem cells. And that's why we call it adipose PRP. It has a lot of stem cells, but we can't call it stem cells for FDA reasons, and because we're not using enzymes, digestion, and finally, we inject inside the ovaries. Are there studies? The answer is yes. This is a trial in women with premature ovarian insufficiency where they did autologous adipose-derived mesenchymal stem cells and inject them inside the ovary. Those are women who don't have periods for 6 to 12 months. And what they found out, it's a small sample size. The first 3 patients, they did low concentration, 5 million stem cells, and then 10 million, then 50 million, so 333. And if you look at the red bars, red meaning periods. So 1, 2, 3, 4 out of 9 women had periods. The effect started approximately 1 month after the procedure, and the latest effect was up to 8 months, right? But if you look, it's really between 1 month and 6 months. If you look at all those activities, between 1 and 6 months is what's the most. That's why I tell patients it's good for up to 6 months. You might see, in fact, the regular PRP without the adipose, I've noticed based on our experience, is good for 3 months. After 3 months, the effect usually is gone. Now, are there babies? That study did not look at babies. The answer is we just published last month the first live birth in women over 45 years old, and there was a study published, a small case series, an American Journal of Stem Cells delivered healthy babies, and those women were over 45. I'm happy to share the study, but it's also on our website. Now, what we know so far about the adipose is that if you look at the study on the 9 women in our case reports, 44% resumed menstruation. 50% experienced menstruation 1 month after the procedure, and 50% in the second month of procedure. So it might take up to 2 months in certain patients to kick in. Menstruation continued up to 8 months, and we've published the first live birth in women older than 45. Of course, there is drawbacks and limitations similar to PRP. There is same questions, same concerns, same ethical concerns, same long-term follow-ups. But the future directions really should work with, we want to work with the FDA to kind of, of course, under IND to kind of isolate more stem cells and concentrate them and stuff like that. But it's challenging to work with the FDA. Let's put it this way. I'm not sure if you guys did that, but we respect their work, but you would just need them to be a little bit more responsive to our demands. But the third type, so now we talked PRP, adipose PRP, and finally we're going to talk about umbilical cord stem cells. This is an ongoing research project. We're doing it in the Bahamas. Those are stem cells coming from newborn babies in the United States. Those babies are born by cesarean section, not vaginal delivery, in order not to have any infection. And then the companies in the US, there's a lot of them now, they extract the cord blood from these newborn babies at the time of delivery, remove the cord blood, extract stem cells, and sell them to a lot of doctors. Now, because they're coming from third party, if I want to take them, put them in some patients' ovaries, they are not from her. So I cannot do this in the United States, according to the FDA. That's why we're doing it in the Bahamas, and that's why we're doing the research in the Bahamas as well. So we are in collaboration with Doctors Hospital, which is one of the best hospitals in the Caribbean, affiliated with a lot of respectful universities. And we also are in collaboration with Dr. Ayman Al-Hindi, who is a professor at University of Chicago and one of the pioneers in stem cells. Now, stem cells, this is a stem cell. It has a nucleus and it has cytoplasm and a lot of things. Now, the nice thing about them is they release bubbles called exosomes. These bubbles, I call them bubbles, but really like vesicles. They have everything you need in a stem cell without having the stem cell and the nucleus. So really, they're very, very safe as far as I'm talking about, as far as contamination, DNA, or if someone is worried about cancer. So I really like a lot exosomes because they're really the chance of having side effects or anything like this, even though I haven't had side effect with the umbilical cord stem cells, but the exosomes are really neat, and they've been shown to be as effective as the stem cells themselves. Now, we looking at women with diminished ovarian reserve and premature ovarian insufficiency, and the reason why we're studying this is really POI, or premature ovarian insufficiency, has jumped from 1% to 3.5, actually, not 3.5% in women in the United States. So it really that's a 350% increase over the last decade. So it's really a pandemic that nobody talks about. And I can tell you, there's no other explanation other than environmental factors causing women to go into premature ovarian insufficiency. If anybody has any other reasons, please let me know. So it's diet, environment, toxins, all those things, cell phone radiation, all those things, so we really are going to see a jump in women going to menopause who are younger than 40. That's why POI by definition is. And it's really scary if we don't do something. But we're looking at, we have primary, secondary, tertiary objective of the study. We are going to have very tight inclusion criteria. All these has to be met. And we're going to follow patients for up to 12 months with serial testing. And we're going to use 3 doses. We're going to start with exosomes, 15 billion. This is in the billion, 15, 30, and 60 billion in certain subjects in order to see the outcome. Now, all I can tell you this is that, in conclusion, is that ovarian rejuvenation seems to be safe so far, could be effective in improving markers of ovarian reserve and producing healthy babies. And it can show a promise for women and menopause and other things that are not don't want to take hormone replacement therapy to improve their menopausal symptoms, hot flashes, and other things. So thank you so much for having me. And this is our website, rejuvenatingfertility.com. And the Bahamas website is rfcbahamas.com. And these are our Instagram. So thank you so much. Can't
Emma,
hear
go
you,
ahead
Emma.
and unmute.
Sorry. Okay. Thank you. Super, super interesting and very well done topic and presentation.
Thank you.
I love it. I mean, really, really, it's not something very usual. You know, it's a very particular topic. And I see a question here that
before we get to that, Emma,
yeah,
unless you have a list of questions, I have questions prepared.
I have two.
Okay, do your questions before that question.
So when you talk about egg quality, okay, you are referring to morphological egg quality or more molecular? I mean, you know what I mean?
When I talk about quality, I talk more about fertilization, embryo development, because our goal is really baby, right? And
Yeah.
what we did, actually, Dr. Seren Sechkin, she's a generation next. She's great. She was our fellow at the fertility, my fellow. And what we did is we looked at women who did, what do you call it? IVF. The women have low ovarian reserve. They did IVF. Cycle 1, then they did PRP, then they did cycle 2, and we compared the outcome of cycle 2 to cycle 1. And we found 4 to 5 times higher chances of having euploid embryo.
Okay, so you're talking more like internal morphology, not really outside, you know what I mean? Because yeah, go ahead, sorry.
No, I'm talking about blastocyst development and euploidy, because look, the problem with aging and endometriosis is the meiosis. The division of the egg is the problem. And what causes the division of the DNA? Because our DNA is 46 chromosome, but her eggs split in the ovary to 23 as the follicles maturing. The mitochondria and the inflammation, it's cutting these DNA unequally to 24-22 or 25-21. That's what's causing aneuploidy. Yeah. So it's the mitochondria that causes this. That's why we do MRT in the Bahamas, right? But the PRP has a lot of growth factor that improves the function of the mitochondria and anti-inflammation, then ultimately leading to better division of the DNA and equal division leading to euploid embryos.
Okay.
So that's how the mechanistically it works.
That's very important because at the end is what we want, as you said. Yeah, is the baby. Right. But have you seen any marker, like morphological markers for the eggs? Any?
We did not look at that. I mean, we looked at the AMH, a number of follicle. Yeah, it's increased. Yeah, I don't get excited about it, honestly. Yeah. Quantity does not mean anything. No, I really care about quality. Yeah. Patient get excited and I tell them, let's wait and make a baby first. So really, there are mechanistic ways as to why PRP works, right? Okay. It's not just because, you know what I mean? There is mechanistic. But also, Emma, and I mentioned earlier, that division, the higher the dose of medication, if someone did PRP, the Menopur, and you're rushing that egg to split. It's more likely to do mistakes.
It's very not natural. I mean, it's unnatural.
More likely get aneuploid embryos, and that's why high dose is bad, and that's why high dose and inflammation and endometriosis. The more you give, the more likely you get aneuploid embryos because you're rushing the egg to split. It's not taking its time, and you get unequal division.
So do you think that, for example, those clinics that they do PRP on let's say regular IVF cycle, they do worse or is completely like nothing? I mean, doesn't do anything, the PRP. I mean, you said that PRP works when the stimulation is not a regular one, okay? And if they do with the regular one, it's gonna be worse or the same?
But that's why some of the trial that I told you, they did not find a benefit of PRP because they pumped them with a lot of shots. You're
So
not gonna
yeah, is
see.
it really?
So your mask, you really deleted every effect of PRP you've done with it. You're not gonna find a better outcome. That's why less is better.
Yeah, I got it. Yeah, very interesting, super interesting. And let me see if I had. No, basically, my question were all very related to the oocyte quality. If you had, as I said, any markers, and if in regular stimulation, was worse or nothing, or
Yeah.
better.
I don't do heavy stimulation ever in those
Yeah.
patients, but as far as meiosis and egg quality, there are studies on mice models where they looked at markers and they found that meiosis and the egg quality is better.
Okay.
Happy to
Wow.
share them with you as well.
Actually, that
Absolutely.
would be a very interesting study.
Oh, absolutely.
Yeah, to do even
There are
on, patients' eggs and see.
I mean, if you go to PubMed and put PRP and ovaries, you'll find over 170,
I know it's crazy. Yeah,
papers.
but
So when people say, oh, there is no studies, it drives me insane.
what? No,
You know
there
what I
are
mean?
many. I mean, now it's very well, studied.
Yeah.
That's right. Okay. So, Sally, what about you? Any?
Oh, well, first I have a number of questions, but you should know that Dr. Vidali has texted,
Oh
and
God.
we're gonna go to the Bahamas and film there and also watch you work because neither of us have been to but we can't
I would
wait.
love to. I'll fly him and you on me.
Yeah,
Oh,
How about that?
and the
we
dogs.
can't wait.
I'll put you in the
And then he
Bahamar
also
hotel.
invited you to next year's in-person conference. Don't worry,
Yeah,
you're part of the family now.
yeah.
So I have some questions. Is there any value? There are some surgeons who, when they operate on the endometrioma, then they're doing PRP at the time of surgery. Have you seen that done for like ovarian reserve and not just for adhesion prevention? Because they also do PRP for adhesion prevention.
Yeah, I don't know the answer, honestly. Sorry, I'm not aware of any study that did this, and I know doctors are doing it, which is actually great because patient is there and you're seeing the ovary and you can inject how much you want under visualization, under laparoscopically. So I think it's a great idea, but I'm not aware of any study that really did this and followed patients to see if they did better or worse.
Oh, interesting. Okay, so by the way, people submit questions, so I have them
Oh,
on
you
my
can,
side.
sure, you
Okay,
can ask
yeah.
whatever you want.
So, what might be when someone has endometriosis, which you guys were alluding to this in the previous conversation, how might you change the IVF cycle for them? Like, do you change it at all?
Oh, absolutely. Look, I mean, endometriosis is estrogen sensitive. The more estrogen, the worse it is. So it's very important. And I hate this comparison, but they're not the same. But in my head, it's like breast cancer IVF cycle, right? They don't like you don't want to give them high estrogen for breast cancer because you make it worse. Same thing. You give them letrozole and you try to keep the letrozole as long as possible during the stimulation to keep that estradiol lower, and you give lower dose. So letrozole is a key in this. And two, suppression with birth control pill for a week to 10 days before stimulation is very important. So suppression, and then mini stimulation, and finally adding letrozole. Those are the three key. Now I told you all my secrets, Sally. I have to keep you.
All the secrets. Well, that's the goal. We need all the secrets.
But this is how we do endometriosis. Yeah.
So I'm curious because our number one question that we get asked for fertility, and I also had a patient call me in a panic about this too because she went from surgery to IVF is, do the drugs make the endometriosis grow? Have you seen that in your clinical experience?
The answer is should be mechanistically speaking, it's like fibroids. They're both sensitive to estrogen. When you give medication, the fibroid grows. In pregnancy, a lot of fibroids grow and they act during pregnancy because the estradiol is high. So the answer is yes. The question, is it temporary or permanent? I don't know the answer. I really don't. But on the short term, it definitely flare it up and make it worse. I think, again, common sense tells me that once you stop the stimulation, it should shrink and go back to where it was. But I don't know the answer, and it's hard to see it.
Yeah. I also find my uncle's research is on the connection between hot flashes and cardiac health, right? So that when menopause comes,
Mhm.
those with hot flashes, and we aired that research last year, those with hot flashes have a much higher incidence of, those are the people who are going to have cardiac issues related to menopause. So I'm fascinated by what you're doing with the stem cells and the hot flashes.
Thank you. Yeah, I mean, look, even women with low AMH have been shown to have more heart disease later on.
Yeah.
So women at the same age, if you have a 30-year-old, two 30-year-old twins, one have low AMH, one doesn't. The one with the low AMH have higher risk of heart attack later on because the ovary is really, and this again, I always tell people, you're not just an egg. All this is connected with each other. So you can't treat somebody as an egg or as a uterus. It's really the heart is even has issues with the low ovarian reserve. They're connected. So it's all interlinked together, right? But yeah, it's very interesting.
Right. We even see those with hysterectomy, higher incidence of cardiac related issues as
Yep.
well. Even with keeping the ovaries, there's still a higher incidence there. That's why. So we stepped into it because this is like family research. That's what he does. But very interesting trying to extend that from the ovary perspective rather than just give HRT to try
Right.
to, like, it's almost like giving birth control instead of solving the problem. It's very interesting what you're doing there. Yes,
Thank you.
we'll be down to the Bahamas. We'll check it all
I
out.
Sure.
told you.
I'll bring him. He'll love it. So we have a question about
Yeah.
adenomyosis. And we focused on adenomyosis last week, but I'm curious, what about PRP and adenomyosis? Have you seen any results with that?
The answer is yes. If you look at PubMed, there is zero studies right now looked at PRP and adenomyosis. There's a lot of studies on PRP and infusion in the uterus for Asherman syndrome. We do PRP of the uterus as well, and this is actually, we're seeing great things. Asherman syndrome, we inject PRP, not just infusion. We inject by hysteroscopy inside the lining or under the lining to improve the lining, development because, as I mentioned earlier, the menses have stem cells and the lining have stem cells. When you inject PRP, you activate those stem cells to become a new fresh lining, and this lining holds the pregnancy better. So we know that it helps with thin lining, it helps with Asherman syndrome. I can tell you, I've done it on some adenomyosis patients. I've seen some patients responded, some patients did not. It's actually on my list of research of things to do, believe it or not.
It'd
So
be
I
very
am
interesting.
planning to recruit adenomyosis and do that and see if it helps.
Well, Andrea, Dr. Vidali, is now doing the microwave ablation for both focal and diffuse adenomyosis. And it'd be interesting to combine the two
Yeah.
because once you sort of have this better lining from the microwave ablation, then you could use the PRP to stimulate it to
Mhm.
be like fluffier and healthier, maybe. I like how
Yeah,
I like to make things up and then send them on their way to do the
but
research.
you're right, and there are studies on stem cell, adipose stem cell, and umbilical cord stem cell, and the injections of the lining that build the lining in a lot of women with Asherman syndrome. We know that there's plenty of studies on it, but the adenomyosis in particular is actually, like I said to you, it's on my list of people of things to study, and I will be recruiting patients with adenomyosis. So if you know anybody,
Oh,
we'll give it to
We
them
know
for
a
free.
lot.
we
For
know a
free.
lot. It's a
Yeah.
very big issue in
Yeah.
the endometriosis community because we can manage the endometriosis with excision, but then after that, the adenomyosis is very difficult. We had an excellent video last week. I'll have to upload it to you.
So we should collaborate and really we'll
Yeah.
offer them free PRP for the lining injections, and we can see if they do better. We need to because adenomyosis is painful, as you
Oh,
know.
yeah.
It also makes implantation very difficult, right?
Yep.
And also a lot of miscarriage, remember, on the second trimester.
Yeah.
What do you think about the doctor that presented last week was talking a lot about using frozen embryos with adenomyosis? What's your opinion on that?
Well, I respect Dr. Gleicher a lot, and you know
Oh,
he's
it
really
was the
great.
other one. It was Dr.
Oh,
Mawad, but
oh, I'm
yeah.
sorry. I thought to use a frozen, well, it makes more sense to use frozen with adenomyosis because if you're doing fresh, you're stimulating the ovaries, and those stimulation are going to the adenomyosis, and also it flares. It's similar to endometriosis, so it's best to freeze them and then give some type of suppression. I like Orilissa more than Lupron. There is one study by Dr. Ayman Al-Hindi, who's actually I just mentioned his name. They give Orilissa for adenomyosis before, and because it has less side effect. It helps shrink the endometriosis and adenomyosis 2 months, and then I do a frozen embryo transfer. That's what I do for my adenomyosis patients.
Interesting. Very nice.
Yeah.
It's interesting because in the surgical world, we hate suppression and we hate the Orlissa. And then when you start to work in the fertility world, if it's a component to treatment, it's very different than being given as the only treatment.
Yeah, well, you're treating somebody for long term. We're just treating for implantation, that short phase. So I want to do anything to kind of slow things down to make that embryo stick. You know what I mean? But you are right. The pills are not going to cure endometriosis. Surgery is better on the long term. So I think we're both talking about a little bit different angles.
Different, yeah.
It's always hard to get the patients to understand both angles, that one is long-term and one is when goal is baby. Yeah.
Right, exactly. Exactly.
Yes. Emma, any other question? We do have the Q&A open. We are being shared like crazy on Facebook, which is kind of nice. I like to see that.
That's nice.
What other questions do you have, Emma?
Well, add me as a collaborator so I can also share on my Instagram.
Absolutely. We're going to get the clips up also.
Definitely. I think that he was, he's explained everything really well. And I understood the whole, thing.
Concept.
Yes, that's actually very, very nice. And it's super interesting. I'm not kidding. The whole presentation, it was great. And the topic is top.
Thank you.
Top topic.
Thank you.
Okay,
now,
so Sally, go ahead.
I don't do a lot of the fertility side, although I can, but before we went live, I said, well, I'm so happy that Dr. Murhai is here because this is my whole story. And the reality is that mostly due to aggressive surgery that was maybe too aggressive, I had both premature ovarian failure and then I had no ability to get eggs out even with 3 rounds of IVF. And so that was like 10 years ago. So it's nice to see the research that shows how far we've come and what could be done now.
Yeah. Well, speaking of that, I think in 3 years, you're going to be able to make eggs from your own skin.
Yeah.
With in vitro gametogenesis. And Dr. Matilopop, I'm sorry, I can't, I'm saying his name incorrectly. He's at University of Oregon. He was able to make an embryo from the skin of a woman.
Very interesting.
Right.
Book that up, Emma. Let's book him.
So,
okay, another one.
So the reality is in 3 years, I think, any woman even if she's 100 years old, she can have a biologically related child using a surrogate to carry her baby.
Yeah, very interesting. I think like we get, Emma, you get the phone calls too with people who have like no hope left. And when you see webinars like this, you realize that just
you really have completely change the view of these people. Yeah, it's a very nice hope.
All right.
Great. Thank
So
you.
we're so happy to have you here.
Yeah.
My pleasure.
Our next session will be on shockwave therapy,
Oh,
which is for vulvodynia and pelvic pain, so a little bit different. But those of you that are logged on to our fertility session, we want to remind you that the Endometriosis Summit is coming up March 27th through the 29th. I am marking 2 sections of the summit sold out tomorrow morning. So if you want to get into the summit, get in now. But Emma will be there.
Yes.
And Dr. Vidali will be there. And also next week's guest will be there. And by the way, Dr. Murhai was already invited for next year.
thank you.
Andrea
Yes,
has a
yes,
whole thing
yes.
scheduled for him for next year. And so if you're looking for tickets, www.theendometriosissummit.com. And those of you that are waiting, you can stay on or we'll see you later.
Thank you
So
so
it's
much, Sally.
Perfect. Thank you,
so
guys.
nice
See
to
you
Thank
at
you
the
meet
so
next.
much.
everybody.
Bye. Thank
Bye.
you. Bye
Bye-bye.
bye. Take care.